Let us read about lung cancer. Bronchogenic carcinoma. Lung cancer is the number one cancer killer among men and women. For men, the incidence of lung cancer has remained relatively constant, but in women it continues to rise. Lung cancer affects primarily those in the 6th or 7th decade of life. Less than 5% of patients are under age of 40. In approximately 70% of lung cancer patients, the disease has spread to regional lymphatics and other sites by the time of diagnosis. As a result, a long-term survival rate for lung cancer patients is low. Evidence indicates that carcinoma tends to rise from at sites of previous scarring, TB, fibrosis in the lung. More than 80% of lung cancers are caused by inhalation of carcinogenic chemicals, most commonly cigarette smoking. Pathophysiology. Lung cancers arise from a single transformed epithelial cell in the tracheobronchial airways. A carcinogen, cigarette smoke, radon gas, other occupational and environmental agents, binds to the cell's DNA and damages it. This damage results in cellular changes, abnormal cell growth, and eventually a malignant cell. As the damaged DNA is passed on to the daughter cells, the DNA undergoes further changes and becomes unstable. With the accumulation of genetic changes, the pulmonary epithelium undergoes malignant transformation from normal epithelium to eventual invasive carcinoma. Squamous cell carcinoma is more centrally located and arises more commonly in the segmental and subsegmental bronchi in response to repetitive carcinogenic exposures. Adenocarcinoma is the most prevalent carcinoma of the lung for both men and women. It presents more peripherally as peripheral masses or nodules and often metastasis. Large cell carcinoma, also called undifferentiated carcinoma, is a fast growing tumor that tends to arise peripherally. Bronchoalveolar cell cancer arises from the terminal bronchus and alveoli and is usually slower growing as compared to other bronchogenic carcinomas. Lastly, small cell carcinomas arise primarily as a proximal lesion or lesions but may arise in any part of the tracheobronchial tree. Classification and staging. Non-small cell carcinoma represents 70% to 75% of tumors. Small cell carcinoma represents 15 to 20% of tumors. For non-small cell carcinoma, the cell types include squamous cell carcinoma 30%, large cell carcinoma 10 to 16%, and adenocarcinoma 31 to 34%, including bronchoalveolar carcinoma, that is 3 to 4%. Most small cell carcinoma arise in the major bronchi and spread by infiltration along the bronchial wall. Small cell cancers account for 20 to 25% of all bronchogenic cancers. In addition to cell type, lung cancers also are staged. The stage of the tumor refers to the size of the tumor, its location, whether lymph nodes are involved, and whether the cancer has spread. The non-small cell lung cancer is stage 1 to 4. Stage 1 is the earliest stage with the highest cure rates, while stage 4 designates metastatic spread. Small cell lung cancers are classified as limited or extensive. Risk factors. The risk factors are tobacco smoke, second-hand passive smoke, environmental and occupational exposures, gender, genetics, and dietary deficits. Other factors that have been associated with lung cancer include genetic predisposition and other underlying respiratory diseases such as COPD and tuberculosis. Tobacco smoke. More than 85% of lung cancers are attributable to inhalation of carcinogenic chemicals such as cigarette smoke. Lung cancer is 10 times more common in cigarette smokers than non-smokers. Risk is determined by the pack year history, that is, number of packs of cigarettes used each day multiplied by the number of years smoked. The age of initiation of smoking and the depth of inhalation and the tar and nicotine levels in the cigarettes were smoked. The younger a person is when he or she starts smoking, the greater the risk of developing lung cancer. The risk of lung cancer decreases as the duration of smoking cessation increases. Secondhand smoke. Passive smoking has been identified as a possible cause of lung cancer in non smokers. In other words, people who are involuntarily exposed to tobacco smoke in a closed environment, that is, home, car, and building, are at increased risk for developing lung cancer as compared to unexposed non smokers. An average lifetime passive smoke exposure to a smoking spouse or partner increases a non-smoker's risk of lung cancer by about 35% compared to the risk of 100% for a lifetime of active smoking. Environmental and occupational exposure. Various carcinogens have been identified in the atmosphere, including motor vehicle emissions and pollutants from refineries and manufacturing plants. Evidence suggests that the incidence of lung cancer is greater in urban areas as a result of buildup of pollutants and motor vehicle emissions. Radon is the colorless, odorless gas found in soil and rocks. For many years, it has been associated with the uranium mines, but it is now known to seep into homes through ground rock. High levels of radon have been associated with the development of lung cancer, especially when combined with cigarette smoking. Home owners are advised to have radon levels checked in their houses and to arrange for special venting if the levels are high. Chronic exposure to industrial carcinogens such as arsenic, asbestos, mustard gas, chromates, coke oven fumes, nickel, oil, and radiation has been associated with the development of lung cancer. Laws have been passed to control exposure to such elements in the workplace. Genetics. Some familial predisposition to lung cancer seems apparent because the incidence of lung cancer is in close relatives of patients with lung cancer appears to be 2 or 3 times that of general population regardless of smoking status. Dietary factors. Prior research has recommended that smokers who eat a diet low in fruits and vegetables have an increased risk of developing lung cancer. The actual active agents in a diet rich in fruits and vegetables have yet to be determined. It has been hypothesized that carotenoids, particularly keratin or vitamin A, may be important. Several ongoing trials may help to determine if keratin supplementation has anti-cancer properties. Other nutrients including vitamin E, selenium, vitamin C, fat and retinoids are also being evaluated regarding their protective role against lung cancer. Clinical manifestations. Lung cancer develops insidiously and asymptomatic until late in the course. The signs and symptoms depend on the location and size of the tumor, the degree of obstruction, and the existence of metastasis to regional and to distant sites. The most frequent symptom of lung cancer is cough or change in chronic cough. The cough starts as a dry, persistent cough without sputum production. When obstruction of airways occurs, the cough may become productive due to infection. Second one, wheezing. Patients also may report dyspnea, hemoptysis, or blood-tinged sputum may be expectorated, and recurring fever. With repeated unresolved upper respiratory tract infection, chest or shoulder pain may indicate chest wall or pleural involvement by the tumor. Pain also a late manifestation and may be related to metastasis to the bone. If the tumor spreads to adjacent structures, regional lymph nodes, the patient may present chest pain and tightness, hoarseness of voice involving the recurrent laryngeal nerve, dysphagia, head and neck edema, symptoms of pleural and pericardial effusion. The most common sites of metastasis are lymph nodes, bone, brain, contralateral lung, adrenal glands, and liver. Non-specific symptoms are weakness, anorexia, and weight loss also may be a diagnostic. Assessment and diagnostic findings by chest X-ray, CT scans, sputum cytology, fiber-optic bronchoscopy, and transthoracic fine needle aspiration may be performed under CT, and endoscopic or esophageal ultrasound may be used to obtain transesophageal biopsy, and positron emission tomography PET, magnetic resonance imaging MRI, mediastinoscopy or mediastinostomy may be used to obtain biopsy samples from lymph nodes in the mediastinum. Pulmonary function tests, arterial blood gas analysis, ventilation perfusion scans also used to diagnose. Medical management. The objective of management is to provide a cure if possible. Treatment depends on the cell type, the stage of disease, and the physiologic status of the patient. In general, treatment may involve surgery, radiation therapy, or chemotherapy, or a combination of these. Newer and more specific therapies to modulate the immune system, that is gene therapy, a therapy with defined tumor antigens, or under study and show promise in treating lung cancer. Surgical management. Surgical resection is the preferred method of treating patients with localized non-small cell tumors. No evidence of metastatic spread and adequate cardiopulmonary function. If the patient's cardiovascular status, pulmonary function, and functional status are satisfactory, surgery is generally well tolerated. Coronary artery disease, pulmonary insufficiency, and other comorbidities, however, may contraindicate surgical intervention. The cure rate of surgical resection depends on the type and stage of the cancer. Surgery is primarily used for non-small cell carcinomas because small cell cancer of the lung grows rapidly and metastases early and extensively. Unfortunately, in many patients with bronchogenic cancer, the lesion is inoperable at the time of diagnosis. Several different types of lung resections may be performed. The most common surgical procedure is a small, apparently curable tumor of the lung, that is lobectomy, removal of the lobe of the lung. In some cases, the entire lung may be removed, that is pneumonectomy. Radiation therapy. Radiation therapy may cure a small percentage of patients. It is useful in controlling neoplasms that cannot be surgically resected but are responsive to radiation. Radiation also may be used to reduce the size of the tumor, to make an inoperable tumor operable, or to relieve the pressure of the tumor on vital structures. It can control symptoms of spinal cord metastasis and superior vena cava compression. Also, prophylactic brain irradiation is used in certain patients to treat microscopic metastasis to the brain. Radiation may help relieve cough, chest pain, dyspnea, hemoptysis, and bone and liver pain. Relief of symptoms may last from a few weeks to many months, and it's important in improving the quality of remaining period of life. Radiation therapy usually is toxic to normal tissue within the radiation field, and this may lead to complications such as esophagitis, pneumonitis, and radiation lung fibrosis. These may impair ventilatory and diffusion capacity and significantly reduce pulmonary reserve. The patient's nutritional status, psychological outlook, fatigue level, and signs of anemia and infection are monitored throughout the treatment. Chemotherapy. Chemotherapy is used to alter tumor growth patterns to treat patients with distant metastasis or small cell cancer of the lung, and as an adjunct to surgery or radiation therapy. Combinations of two or more medications may be more beneficial than single dose regimens. A large number of medications are active against lung cancer. A variety of chemotherapeutic agents are used, including alkylating agents, ifosfamide, platinum analogues, cisplatin and carboplatin, taxanes, that is paclitaxel and docetaxel, vinca alkaloids, vinblastine and wind design. Toxorubicin, gemcitabine and vinorelbine, etoposide. Those are the drugs. The choice of agent depends on the growth of the tumor cells and specific phase of the cell cycle and the medication effects. Chemotherapy may provide relief, especially of pain, but does not usually cure the disease, nor does it often prolong life to any great degree. Chemotherapy is also accompanied by side effects. It is valuable in reducing pressure symptoms of lung cancer and in treating brain, spinal cord, and pericardial metastasis. Palliative therapy. Palliative therapy may include radiation therapy to shrink the tumor to provide pain relief, a variety of bronchoscopic interventions to open narrowed bronchus or airway, and pain management and other comfort measures. Evaluation and referral for hospice care are important in planning for comfortable and dignified end-to-life care of the patient and family. Dignified end-of-life care patient of the family. Treatment-related complications. A variety of complications may occur as a result of lung cancer treatments. Radiation therapy may result in diminished cardiopulmonary function and other complications such as pulmonary fibrosis, pericarditis, myelitis, and carpulmonale. Chemotherapy, particularly in combination with radiation therapy, can cause pneumonitis. Pulmonary toxicity is a potential side effect of chemotherapy. Surgical resection may result in respiratory failure, particularly when the cardiopulmonary system is compromised before surgery. Surgical complications and prolonged mechanical ventilation are potential outcomes. Nursing management. Nursing care of the patient addresses the physiologic and psychological needs of the patient. The physiologic problems are primarily due to the respiratory manifestations of the disease. Nursing care includes strategies to ensure relief of pain and discomfort and to prevent complications. Managing symptoms. The nurse instructs the patient and family about the potential side effects of specific treatment and strategies to manage them. Strategies for managing such symptoms as dyspnea, fatigue, nausea and vomiting, and anorexia will assist the patient and family to cope with the therapeutic measures. Relieving breathing problems. Airway clearance techniques are key to maintaining airway patency through the removal of excess secretions. Deep breathing exercise, chest physiotherapy, directed cough, suctioning, and in some instances bronchoscopy. Bronchodilator medications may be prescribed to promote bronchial dilation. As a tumor enlarges or spreads, it may compress the bronchus or involve large area of lung tissue, resulting in an impaired breathing pattern and poor gas exchange. At some stage of disease, supplemental oxygen will probably be necessary. Nursing measures focus on decreasing dyspnea by encouraging the patient to assume positions that promote lung expansion. Breathing exercise for lung expansion and relaxation, and educating the patient on energy conservation and airway clearance techniques. Reducing fatigue. Fatigue is a devastating symptom that affects quality of life in the cancer patient. It is commonly experienced by the lung cancer patient and may be related to the disease itself. The cancer treatment and complications, example anemia, sleep disturbances, pain and discomfort, hypoxemia, poor nutrition, or the psychological ramifications of the disease, that is anxiety and depression. The nurse is educating the patient in energy conservation techniques or referring the patient to the physical therapy, occupational therapy, or pulmonary rehabilitation program may be helpful. Providing psychological support. The psychological support and the identification of potential resources for the patient and family is must. The nurse must help the patient and family with informed decision making regarding the possible treatment options, methods to maintain the patient's quality of life during the course of the disease, and end of life treatment options. Thank you.